So for those who may not be aware, Quality of Care NL functioned as the secretary for the health accord process, which meant that we were involved with project management and logistical support for the task force during the development of the various recommendations. In addition, several members of the staff and the group participated in the work groups and were involved in evidence generation to support recommendations. The final health report, the health accord report rather, was delivered on February 2022 for implementation in June of that year. So tonight, we're happy to bring together some of the leadership involved in the implementation of the health accord, the recommendations thereof, and to provide a checkpoint for us on the progress towards implementation. So shortly, you're going to hear from three speakers. Here to my left in the room sits Elizabeth Davis, co-chair of the Health Accord NL. Next to her, Dr. Pat Parfrey, Deputy Minister of Health currently and co-chair of Health Accord NL. And then at the end of the row, David Diamond, CEO, NL Health Services. They have a presentation to share with you tonight, and then we'll follow this with a question and answer session, both for people attending online and here in the room. So to get us started, I'm going to welcome Sister Elizabeth Davis.
Thank you, Brendan. Thank you to your team. It's rare that you get an opportunity after having done some major work to come back and see how it's being implemented. So it's both a joy and a privilege for me to speak to you tonight. What I will do is simply remind all of us where this came from, and then we will hear from Pat and David about how now it's unfolding. The health accord itself, as you know, was desperately needed in the province, and not just for one reason, but for actually 5 different reasons. First, we have a health crisis. When we look at our health outcomes compared to others across the country, when we look at the inequity among the people within the province, we recognize all is not where it needed to be. We also have experienced in this province, almost the developed world, a significant demographic change that has seen us lose a large percentage of our children and have a much older population than the other provinces. We also know, in concert with every province in Canada, that our current model of healthcare is not sustainable. We recognize, again, like other provinces, that we face fiscal crisis. Now, with the whole world, we are in a global change, actually a time of global climate change emergency, in fact, and we know that's more quickly overtaking poverty as one of the leading causes of illness and disease in our world. So any of those would have warranted major study. All 5 together demanded a major study and a major response. When we look at perhaps the most significant visionary piece of our work was our recognition that the health outcomes and health equity or inequity we experience as a province is rooted less in the quality of our healthcare system than it is in the quality of our social, economic, and environmental factors. So if we're going to bring about the degree of dramatic we need to bring about, we can only do it by addressing the social determinants of health, these social, economic, and environmental factors in which every one of us lives. Certainly the health system has some part in our health, but not to the extent that these social determinants of health have. So therefore, when we put the 2 things together, our vision that came out of the health accord, came out quite early, but was consistently reinforced as the health accord work unfolded, was that we could only improve the health and health outcomes of the people of this province, improve health equity within our province if we attended to 2 things. 1, we accepted and intervened in the social, economic, and environmental factors, the determinants of health, and at the same time worked in tandem with that, rebalancing our health system across community, hospital, and long-term care services. That vision, which sounds so simple, actually is very rare to see that in the same sentence. When we move at how we did our work together, really what we did, there was a large body of evidence gathered in this province, large body of evidence across Canada and globally that we could turn to. So our work was evidence informed. We developed strategies to help us develop further the most key learnings from the evidence. But perhaps most importantly, we engaged with the public. This is not consulting with the public or informing the public, but we truly engage with the public because it's the public's health we're talking about, not my health or Pat's health. So we felt that in using those three key pillars, if you will, evidence, strategies, and public engagement, we framed together an accord, meaning all of us were engaged, not just government, not just the health system, not just the social system, but all the people of the province would be together engaged, working together in changing the health outcomes, which will require time. And we would need to do that, of course, in a fiscally responsible way. I mentioned the importance of engagement, and we were amazed at the extent of engagement we were invited into over the course of the 18 months of this accord. The media were the news media were more than helpful in helping bring our message to the people and bringing the message back from the people. We had public engagement sessions, we had targeted engagement sessions, we had electronic communications, every means that we could use in this day and age to learn from people of all sectors of our province what we needed to attend to. The work then of the Health Accord was produced in print, and that was produced in a report. And the title of this report is extremely important to the vision. Our province, our health, our future, a 10-year transformation. We have a full report. We had a summary of our report in the multiple languages of this province, French, English, Inuktitut, Inuimun, and ASL. And then we had two further documents to give some insight or some wisdom to government about a blueprint for how this best could unfold. We also then, as it did begin to unfold, we began to imagine how best to bring this message to everyone. So we use this rather creative bridge, I suppose you would say. One of the pillars is the social determinants of health. And in that pillar, we looked at most broadly poverty reduction, inclusion, climate change, children and youth, aging, and wellness. The second pillar around the rebalanced health system, we looked at everything from the community to mental health to seniors' health to emergency services to planned hospitals. But none of that is, the living out of those, if you will, requires what we call pathways to change. The people who bring about that change, how the people who bring about that change themselves are recruited and retained, how they're educated, all of the tools that we use in a modern time to bring about change management. Only when all of this comes together will we get the balance we need among the social determinants of health and the health system, and only then we get better outcomes, greater health equity, better health for the province. We used one of our iconic images, if you will, from the Health Accord, is shown on the next slide. In a video, I understand.
What will Newfoundland and Labrador look like when Health Accord NL is fully implemented? As the calls for action are developed, we can imagine the following framework emerging. The person and the family are at the center, you and your family. Your community, which will change over time, is that space in which you are born, in which you live and grow, in which you eat and exercise, in which you learn and work and play, in which you are respected and feel safe no matter what group or race you belong to, and in which you age with dignity and autonomy. Social, economic, and environmental conditions influence your health and the health of your family, your community, and your province. We will know that influence is positive when there are social supports available to you, when you have a voice in what matters to you, when you enjoy good quality food and water, when your home is safe and warm, when there are strong efforts to reduce poverty in your area, when the school system serves your children well, when the justice system protects you, and when any signs of systemic racism and discrimination in your community are recognized and addressed. Our health and social systems are truly based in the community. Primary health care, health professionals, publicly and privately funded, care for older people, social programs, local acute care services, hospitals, and community groups work together with a focus on helping you and your family be as healthy as possible and be supported when you are facing health challenges. Our health and social systems are balanced, collaborative, and connected, linked in real ways, including by information systems. Each one knows where the other is, and each one knows the services and programs which are being provided for you and for your family. To ensure that the circles are connected, pathways link one to the other. Sometimes the pathways are made by community points of contact who collaborate with each other and link social and health programs. Sometimes they are made by virtual care or by information systems. Sometimes these pathways are made by the land and air ambulance system. Sometimes they are made by navigators whose only purpose is to help cross the lines that in the past have been too easily. We will know that Health Accord NL is fully implemented when we are aware that specific social, economic, and environmental conditions are affecting your health, and we are doing something about them. When health and social systems are balanced and are collaborating to ensure that you will have better health outcomes. When every organization asks the question, how will this affect health in the community, before they ever make a major decision? When we have lower rates of chronic illness and fewer deaths from stroke, heart disease, and cancer. When every person feels safe and protected, no matter what their age or what group they belong to. When the health of the people of our province is as good as the health of those in other provinces. When each one of us takes responsibility for ensuring that we are all healthy. We deserve no less. Together, transform health in Newfoundland and Labrador.
That's the dream. And we can say it's idealistic. It is not. It is realistic, but it will take time. And what we know from our own lived experience is that cycle that brings about the depth of change that's required to achieve that vision will take time. And it's not linear. It really is a circular, intersecting kind of cycle. That policy, we have that well embedded in the Healthcare Accord documentation. It leads to action. Pat and David will talk to you about that action. It will require continuous evaluation, well, beginning as the action actually begins, and ultimately will lead to the culture change that's required to make what you just heard in that very short video become the reality in this province. That can't happen overnight. It can't happen, though, unless we begin to make it happen step by step by step, and then are persistent in evaluating what we're doing, persistent in making sure that leadership is accountable for carrying us in those directions, and persistent in believing that that dream that video reflects is worth working for. So Pat, will you tell us how this is beginning to happen?
Ask. So there were 59 calls to action. in the next 45 minutes, our best to give you a reflection of. Thank you. Sorry, in the next 45 minutes, myself and David will try and identify. I think we're going to use this image of the bridge throughout the presentation to give you a sense of whether we're creating a foundation for change. And as it stands at the moment, or as it stands when we started 20 months ago, we had the pillar of the social determinants of health, but these various building blocks, all in silos, all requiring policy and all requiring implementation bit by bit. And on the right-hand side, you have the integration of the healthcare system from the community, the acute care hospitals to the long-term care facilities, and then bridging those two pillars by these pathways to change that were necessary. All of them individual calls to action, all of them building blocks. And to create that bridge, we needed to act on all of them, to integrate them, and then create that bridge that will allow change to happen and better health outcomes. So we're going to kind of come back to that imaging as we go through. So on the next slide, won't spend long here. The Health Accord made a lot of recommendations about structures that would be necessary to implement change. They've all been implemented. One provincial health authority with regional zones, cabinet committee and seniors, digital health as part of NL Health Services, a provincial data governance strategy is coming soon. An all-party committee to establish an NL Health Council is currently meeting to make recommendations for legislation. So on the next slide, I'm going to re-emphasize what Sister said, which is that we're not going to make Newfoundland and Labrador one of the healthiest provinces unless we're active in the arena of the social determinants of health. Safe housing, good food, clean water, a justice system, prosperity, education, and acting on exclusion, providing equity, social connection, and safety. The next slide, I'm now going to quickly go through the major calls to action and give you an idea of where they are. But before I do that, there's going to be an animation around what we mean by well-being. And we mean it as a term that integrates the social terms of health, population health, health and all policies, as being a catch-all for that arena. So this animation is going to summarize it.
Newfoundland and Labrador is focusing on well-being to become a healthier province. But what is well-being, and why does it matter? Well-being is defined as an overall positive quality of life where a person's needs are met in many important areas. Where and how we live and work, and what supports we have access to, referred to as the social determinants of health, have a strong influence on well-being. We experience far better health outcomes when we have access to safe housing, good food, and clean water, access to quality education from a young age, inclusive and stigma-free social connection, access to a justice system that protects us, access to good medical care and mental health supports, access to income that protects us from poverty. These are just some aspects of health and well-being.
So we've reviewed a lot of information that's come from the quality of life federal framework that compares provinces among multiple indicators. I'm going to give you the detail. I'm just going to give you what our summary was of that information. So in our province, we have strong feelings of good well-being. We are the best in the country, even our life expectancy is the lowest. We have high levels of social cohesion, safe and secure communities, and high confidence in our institutions that demonstrated by our response to vaccination. So we have that basis in which we could anchor change. However, the top right red parallelogram, we're the worst in the country. We were child poverty, early skills and development in youth, And we have a high disease risk predisposing to cardiac disease. And we're told time and time again, as a province, we exclude people, Indigenous, LGBTQ, disabilities, immigrants, people of color. So we feel that as a consequence of that data set that we've examined, that the pieces, priorities we have, investments in priority, particularly childhood poverty, investment in skills and development in early childhood and in youth, particularly the health promotion agenda that focus on where the people are, schools, workplaces and communities, and a disease prevention effort in family communities. And then finally, we should be able to act on inclusion. So on the next slide, what's happened so far in the first 20 months? So the Premier announced a provincial poverty reduction plan. I'm not going to read all of this now here because it's in the public arena. The biggest piece of it was to increase the child benefit by 300%, moving us from our ranking in which was the worst, would now turn out to be the third best. Early childhood nutrition program that was for 1 year, extended to 5 years. Then the proposal that we should have provincial school breakfast and lunch program, which is now in the process of being policy being developed. In addition, for adults, there was a targeted program to provide youth in poverty with their basic income, with support to get them started in life. An introduction to a targeted basic income for people at 60. An increase in income support comfort allowance, and then a streamlining and improvement in income support benefits that will lead to everybody getting a higher income support, and employment interventions that can concern providing employment stability to people on income support as they're transferring to employment. So the next slide, so that's the poverty reduction piece, which has just started. The next piece that was announced by the Premier is that there should be a seniors wellbeing plan, and that is in the process of being developed, and it should be announced. And the pieces that we've received public feedback on, we need to support aging in place. We need to increase income for people who have low incomes. We need to improve access to healthcare. The demand that it was feasible to navigate information, to get information easily electronically, and to navigate the health system. So that policy box is developing. Next slide. You heard the education accord was announced a few weeks ago. It's got 4 elements: early learning and childhood development, education and estimation, health and well-being in education environments, post-secondary education and learning across the lifespan. And they're hoping to use somewhat similar methodology as we use in the health accord to be able to expedite this and engage so that there is action on our education agenda. Next slide. A housing plan was announced. I won't read all this slide because again, it's in the public arena. 5-point plan to stimulate new home construction and stabilize and reduce housing prices. An affordable rental housing program. Planning to integrate health, housing and supportive services in Happy Valley Goose Bay. And planning for 143 provincially owned vacant units. So there's a start to housing. And it's interesting, we didn't identify that as a priority because we have the highest rate of acceptable housing in the country, but the country is not very good. So that's why it became such a priority. The next. The access to early learning and childcare has been facilitated by the federal government program. It's started. There are 8,200 plus new childcare spaces operating in $10 per day or lower. Over 1,000 created in 2023. 18 pre-kindergarten sites opened through the province. 63 child providers in the process of opening not-for-profit childcare centres in Newfoundland and Labrador. So there's been a start to the to trying to do something about early childhood development. And the next slide. An interesting one is the around increasing awareness of the importance of the social determinants of health and healthy living. And there have been a number of things that have happened. There's a public health framework finalized and in the public arena. We had a well-being week to increase awareness of the social determinants of health and engage the community sector. The partnership with the community sector is now going to be involved in creating well-being events in municipalities with the objective of increasing the awareness of the importance of social determinants of health. And then the next one, inclusion. Now, inclusion is probably the most difficult to get a strong handle about how we can change what's happening to these excluded groups. There's a lot of work going on in government to, particularly with Indigenous people and with the LGBT community. But the 5 big groups are persons with disability, the 2 I mentioned, immigrants and visible minorities. So we have a kind of a policy of how we can go forward. We need an approach that is about nothing about us without us, Indigenous distinctions-based and co-developed actions, an approach that includes human rights, intersectorality, universal design, language that speaks to the people that are excluded. The major areas that we believe to be necessary in trying to make the lives of these excluded groups better is around education and training concerning discrimination, action on the social determinants of health, access to equitable, inclusive health services, and there are people in the new NL Health Services that's their job to consider how we can have equitable, inclusive health services. And then the final piece that we think is important is how we bring the thoughts about inclusion to communities in such a way that we can now have what we call well-being communities. The final piece is that clearly we need evaluation about how we are improving the lives of those people who are excluded, but there's a necessity for data governance managed in an ethical manner. Slide, please. Child health was one of the areas that we were concerned about because we had the highest rate of medical complexity amongst children in Canada and a high number of children in care. So the recommended provincial expansion of the children and youth in alternative care, that started. And last year, the visits to that clinic increased by 107%, from 582 to 1105. The other component was child health that had a integrated approach by the health system and worked out partnerships with the education and social system for children who develop various types of health problems, because we have a siloed approach to child health. I can just say that the policy around this new child health model is near finalized and it should be implemented this year. Next slide. So we're trying to assure everybody we're in contact with that we want to be a well-being province, that we have priorities: poverty reduction, education transformation, housing, health promotion, and inclusion, and that we can develop a societal approach that includes the concept that well-being can be driven by what happens in communities. It can be driven by what happens in regions through what we had called regional health and social networks, or now calling regional well-being networks. And the community sector has a big role to play. So we're going forward with that approach. The next slide of what we mean by well-being communities, what the elements are in terms of being able to connect directly with communities. The biggest, and we're learning from what they've done. The elements of a well-being community include age and dementia friendly, digital literacy and supports, volunteer transport organized by community groups, an approach to healthy living, an approach to inclusion, an accessible built environment, supporting low-income seniors in need at home, housing plan, social and civic participation. So the policy around trying to enhance communities to be able to act on well-being is ongoing at the present moment with that type of a lens. So where do we stand today? Where do we stand 20 months later? Well, we've made a start in poverty reduction and in children in care, but we're still in the policy component of major building blocks of the social determinants. Clearly, we want to put those into a strong pillar so that there's action, so that we can demonstrate integrated action in this arena. Next slide. So I'll do this very quickly. So we felt that people wanted to know the 59 calls to action. What's going on? So we can't go through 59 of them, but I can give you pretty good action, pretty good reflection of where we are. So we've got policy and action are the two big things. So this tick mark would mean it's complete. The arrows is in progress. The red line, red circle, not yet implemented. So let's go on to the slide now. So you can see here that the policy frameworks are in progress in a lot of different areas. I'm not going to go down through all of them because I've already spoken about many of them. The pieces are that are relevant, the ones that I should say to you. We had a call to action on legislation for seniors where their needs were enshrined in legislation. Our intention was never to do that in the first 2 years. The climate emergency is another massive arena. We haven't done anything with it. There is work going on in the Department of the Environment, etc. But we, as a health transformation group, that's on our list to get started. Next slide. And then what about action? I've outlined the action. And in particular, there is now a group called Wellbeing NL, whose job is, that Lynn and myself are involved in, to align and coordinate policy and action on social determinants of health, healthy living, wellness. The Cabinet Committee on Seniors is ongoing. There's a food prescribing pilot, and there's a social prescribing pilot for seniors funded. And then the next slide, I'm going to pass over to David now, who's going to discuss the healthcare system. Then I'll come back and discuss the pathways to change.
Thanks very much, Pat. Those of us who have been around in the operations of healthcare systems for a long time will understand that while healthcare systems have an important role to play, we're very much in tune with the comments from Sister Elizabeth earlier that we're only, in fact, for most of us, in terms of our own health in the population, we're not the most important part, even though lots of people perhaps share a different opinion of that. But those of us who work in it would understand. We would also understand that we have a lot of work to do in the healthcare system. If we're going to maximize our contribution in terms of improved access, in ensuring that services are available where they need to be and when people need our services, we've got work to do. And so that's the transformation piece that we had set about. You can see on the slide here, one of the early recommendations that were actioned by government was the announcement on a new provincial health authority. And so NL Health Services has been in operation since last April. We're not a year old yet, we're 11 months, I guess. We created an organization from the 5 previous organizations, the 4 regional health authorities and the Centre for Health. And we've created out of those organizations 5 zones, mostly with the geography that existed with the previous regional health authorities. And that was quite intentional because, this is a massive undertaking in and of itself to merge 5 organizations and all that entails. And it's very easy to spend 3 to 5 years doing nothing else but the organizational restructuring and not actually providing enough bandwidth for people to actually get at the things that are really important for people around things that you'll see. So we've left most of the geography from the regional health authorities as it was previously, and we've split the Eastern Health into 2, an urban zone and a rural zone, to mainly give more attention to the rural part of the old Eastern Health, which was very difficult in our previous structure. So you can see the geographic breakdown in the map. Pat talked about as well. One of the things we've done as part of our organizational structure is we've baked in some capability at the executive level that is totally focused on the transformation work that was envisioned by the health accord. You can see there on your my left-hand side, some of the positions in our org structure: a vice president for transformation and well-being, largely focused on the work around public health and social determinants, a vice president of health systems transformation as well, focused on the health system transformation. We've got a quality and learning systems. And so these are positions that you won't see in many organizations across the country, but coming out of the health accord and the conversation we've had with government, and if we're really going to get serious about transforming the health system, then we need people who are totally dedicated on that. And so you'll see that in our organizational structure. There are a couple of other elements of our structure that helps us with transformation. We have a number of provincial programs. People will be familiar with the cancer care program that operated as a provincial program out of Eastern Health for the last number of years, and that will continue as a provincial program in NLHS. We're going to do cardiovascular services as a provincial program, clinical efficiency, lab and medical imaging, health and corrections will all be run provincially out of provincial structures, and that also will allow us to ensure a level of consistency and standardization of processes and access wherever you live in the province. On the other side of the chart here, you'll see strategic health networks. So in addition to the operations which happens within the zones, the day-to-day operations of hospitals, for example, in the West Coast happens in the West Coast as it always did, regional health authorities in the RHA days. But the mechanism that we've chosen that actually will link all of the zones together so that, again, we drive a level of consistency, focus on access, focus on quality, is a series of strategic health networks. You can see some of the health networks here, the first 4 that we're rolling out almost as we speak. In the next week or so, we'll have 4, one for the care of the older adult, one for emergency care, one for primary health care, and one for surgery. We expect that when we get fully up and operational, we'll have about 15 of these health networks, and that will allow operational leaders, transformation leaders, researchers, innovation folks, quality, change management people to be around the same table and to be able to take some of the recommendations from the health accord in the care of the older adult, for example. Much in the health accord speaks to the need care for seniors. And we see these clinical networks tying the operations together across the 5 zones as being the engine that will drive that work for us in the health system. Family care teams has been another focus, primary care, improvement of primary care, strong focus in the health accord, and it's certainly been between ourselves and Dr. Parkway's group in transformation and the government, the health department. Improving primary care has been one of the areas of major focus in the first 11 months. And we're doing this, of course, through the mechanism of family care teams. And these are collaborative teams, multidisciplinary teams with physicians and nurses, allied health, centered around a catchment area. We'll have family care teams in areas where we have 6,000 to 7,000 people or more. Will form the catchment area for family care teams, and it'll link a lot of the services that we have in the health system, but also broader than that out into the social system. And a lot of the areas of focus that we can impact from a health system perspective, dealing with population health and social determinants around promotion and prevention, chronic disease management, so on, will be centered around these collaborative family care teams. Our intent over time is that everybody in the province, if they choose to be a member, to be attached to a family care team, will have that opportunity. And so far, we've got, I think, 19 of these teams that have been approved, and 15 of them that are 15 that are operational. And we have about 50,000 people as of today who are attached to family care teams, and that's growing on a weekly basis. Here's just another visual that shows the 19 where we have the 19 that are approved. The green you can see mostly in the St. John's area because these were out of the gate earliest. So that we have 4 in the St. John's urban area that are fully operational, and then a number of them that are partially operational, that have most of the members of the team, but not necessarily all of the members of the team. And those are the ones that you see there in yellow. And we have a few red, and there's very specific issues for the in the areas that are red where we haven't achieved yet. But in Labrador West, for example, we've got space now, we've got a manager, and we've got some allied health folks that are in the process of moving in, so that'll turn yellow quickly. In the Brookfield area, we've had a little more trouble in recruiting staff there, so that's still red. Gander will turn yellow shortly. We're just in the process of obtaining space in Gander, and we have the makings of a team there as well. So lots of work there. And as you can see on the slide, more than 50,000 people already attached to these teams. Our expectation would be, and not to get too far ahead of the government discussion, but our expectation is that there will be more approved in the next budget. And I think the health accord talks about up to 35 of these teams. And we think that we'll have the opportunity in the next few months to move closer to that number. Road and air ambulance, another foundational piece envisioned by the health accord and been a big focus of government and the health authority in the last 11 months. The health accord in its discussion and certainly in its report reflects that access to emergency care is a concern almost where province. And if you're in some areas, remote areas in Labrador, for example, it's even more of a problem than it might be for those who live in larger cities, and that certainly came through in the health accord process. The government has done a lot of work this year. They've issued a request for proposal to hire a private company. So road and air ambulance on a go-forward basis will be operated from a management contract by a private company, but they will be actually employees of the health authority. And so it's a mixed model similar to what we do now for housekeeping and food services and so on. We have a management company that has certain expertise. They report to us as if they were our employees, and the paramedics in this case will actually be employees of the health authority. You can see in the circle there the elements of a well-functioning emergency model, central dispatch, 24/7 virtual emergency, virtual emergency physician support, good communications and electronic linkages between all of the assets, the ability to dispatch not just road but air as well. Helicopters is a component that doesn't exist very much now in our current system, but we're envisioning that as one of the assets that will be involved in the new system. And then, of course, the fixed wing aircraft that we current system is a bit of a hodgepodge of different aircraft and different mechanisms. And so this will come together in a more coordinated way to be managed by our new private operator, our management firm, when that's up and running in the fall. Urgent care centers and virtual care, other items referenced in the health accord, and has been work done over the last number of months. Urgent care centers, as some of you may know, involve family physicians, nurse practitioners, nurses, paramedics, and it really is a step between what we know of as traditional emergency services and primary care. They exist in a number of other jurisdictions in the country, and so it's a model that we think will work well for us in the province. We have some in Whitburn and St. Lawrence, for example. We have urgent care centers operational in the last few months, and we're working on obtaining space so that we can do similar models here in St. John's, hopefully with a view to taking some of the pressures off the emergency departments in the city. Virtual care has proliferated quite significantly and has been one of the, it's a technology that I think will help us for the foreseeable future in our ability to provide services everywhere and anywhere in the province. It's certainly been very helpful to us being able to end some of the diversions that we've had in Category B emergency departments. So the virtual capability that we have provides emergency physician support where otherwise we would be diverting people quite a distance away from the category Bs, and we're almost at the point now where diversions of category Bs are non-existent, which is amazing given where we came from even just a year ago. Virtual is the virtual care is supporting the emergency departments, it's supporting the urgent care centers that we have, and it's also supporting some of the gaps we still have in primary care. We've contacted about an additional 50,000. So we have 50,000 people attached to family care teams. There's an additional 50,000 people who are on Patient Connect NL, people who are looking for physicians who have been connected into our virtual care, and over 5,000 of those have signed up to receive primary care services through virtual as well. So that's a part of helping us in this immediate short-term shortages of physicians in particular that we've had. But we think this will be part of the long-term sustainability strategy in the years to come. Seniors care, I'll just touch on a few items here. The Centers for Excellence for Aging, referenced in the health accord. We've got budget money from last year's budget to help us expand what we have been doing already in St. Clair's, and similarly in Corner Brook. Center for Excellence for Aging is developing its planning happening for a similar center in central Newfoundland. There's been work between the health authority and the government and the transformation team that Pat leads and the medical school around training programs for geriatricians to support what we know we need to do in the long term to improve seniors care, and other work there. You can see in number 4 that is underway. So one of our 4 clinical networks, as you'll recall from a previous slide, centers on seniors care, and that network could be up and running in the next couple of weeks. We hope a lot of this activity, us as a health authority, will get centered in the work of that clinical network focused on seniors care. We have also spent a lot of time together with government looking at surgery and the backlogs created particularly as a result of COVID, but exacerbating some wait lists and wait times that we had even prior to COVID. And so we spent a lot of time looking at some very focused areas to improve surgery. And again, I'll go back to the network. One of our early networks will be a network geared to surgery. But you can see here already with focused effort what's happened around joint replacements, and orthopedic surgery was one of the areas of our service that actually took quite a hit through COVID, and lots of our canceled surgeries through the COVID period impacted orthopedic surgery. And so our wait lists have become very long, and our ability to perform surgeries within the recommended timeframes have been quite inhibited. And so you can see here with the focused effort that we've had in the last 11 months around orthopedic surgery, almost a 40% improvement in the number of cases we're able to do this year compared to last. Cardiovascular and stroke in the province of Newfoundland and Labrador, near and dear to most of our hearts, if I could use a pun, but it is one of the diseases that impacts many of us and many of our families, unfortunately, in this province. And so improvements in cardiovascular and stroke care has also been an area of focus between ourselves, transformation, the Department of Health and Community Services, and you may be aware that the government has approved an institute, the development of a cardiovascular and stroke institute. Ultimately, that will result in bricks and mortars of building an actual institute on the Health Sciences Center site. But even before we get, and there's planning, by the way, around that. So that is that the planning for the Cardiovascular Institute as a physical structure, that planning is underway. But even before we get to that, there are some improvements, some significant improvements in cardiovascular and stroke care. The transportation system, you may be familiar with the Heart Force, the scheduled transportation of getting people from across the province who need cardiac cath procedures, which are only done at the Health Sciences Center, picking them up in the morning and bringing them into St. John's, getting their cath done, and if all is well, then they go home in the evening, which has so many benefits in terms of patients and families, but also in terms of our bed flow and not having people tied up in beds unnecessarily. So transport has been a big piece where the cardiologists have been really open to creative new ways of doing business and visiting specialists, having cardiologists go out to other parts of the province has been very much a part of what they're doing. Virtual care has been a big part of the enhancements in cardiac care and the learning health system. And Pat will show you some other graphs later on, but the folks in the cardiovascular program have been on the leading edge of pushing the use of data to help us make decisions. And it's really doing some really interesting, driving some really interesting improvements in cardiac care. One of the privileges I've had since I've been the CEO of this new organization is spending time in Labrador, visiting on the coast and visiting with Indigenous communities and around Labrador, just to understand better the unique needs of that part of the province. And if you want to talk access challenges, you need to go to Black Tickle. So we've spent a lot of time actually as an executive team thinking about, we kind of informally talk about a Northern Health strategy. And there are many things that we think that if we can redirect some of the capability that we have as a provincial health system now to serve the needs of people in Labrador, we think there's an opportunity for some quite significant improvements in services. I won't read all of the boxes here, but air transport is one of the things in the boxes here that actually the whole concept of health force in part came from the challenges in Labrador of trying to get people in through the traditional air ambulance service and all of the delays and all of what that meant. And so transport and air transport and how we get people back and forth and how we use virtual care and how we use visiting specialists so that actually people don't need to travel, which is even more interesting. Looking at the coastal clinics and looking at what we can do with point of care testing and lab and medical imaging. And applying technology. And we've had great interactions with those communities who are actually quite ready for some of the technology and the improvements that we could offer. So the Northern Health Strategy is our informal name for a lot of focus that we have within NLHS to find ways to improve services in Labrador. The health information system, we've had approval for new health information system. Some of those announcements will be made shortly, but over the next 18 months, we're anticipating being able to roll out a state-of-the-art, brand new system to replace our old Meditech system that's 40 years old, and to be able to consolidate many add-ons. So we have literally hundreds of applications. Most of them are Meditech, some of them are not Meditech. And so a brand new state-of-the-art technology that will integrate patient records and patient data and the ability for people to access their data across the province is, again, another foundational piece that we're about to embark on over the next 18 months. A little add-on to that is a conversation we've been having with the government around a digital front door. So even before we get the full HIS rolled out over the next 18 months, there's a project that we're working on in collaboration with government. It's called a digital front door, but essentially it'll be app-based technology that on your smartphone, you'll be able to access your personal health record, make your e-appointments for a variety of services, and it'll be have information available to you to help with navigating the health system. Again, as we know, is a huge challenge and reflected very much in the health accord, how difficult it is to manage. So we'll have this, we think we'll have a prototype ready as early as April of this year on the digital front door, which will give individuals a lot more access to health information than we've had previously. Go back to Pat's graph on the foundational pieces. So the areas under the healthcare bucket, you can see there the things we've talked about: cardiovascular and stroke. Lots happening there to form the foundation of what we need to do for improved healthcare. The surgical backlog we've talked about, the transitions to community care, and some of the work that we're doing in Labrador. And you can see that the other pieces that are yet to fully land, but are very much in the works. Things like ambulance that we've talked about, a child health model, a new child health model that's being developed by government, and NLHS is very much a part of, and seniors care we've talked about. So our hope is that if we're able to see the same kind of progress in the next 11 months as we've had in the first 11 months, when we present this again, everything will be down on the foundation level, and I'm sure there will be other things that we will identify, but we're pleased so far where we are in the healthcare transformation. Similar to Pat's, this is the scorecard for the health system, and these are policy pieces primarily in the purview of government, but we have, of course, an ability as NLHS to speak into those, and I won't go through similar to Pat, but things like the family care team framework and policies from government that's supporting the work we're doing in rolling out the FCTs, the integrated child model that's being developed, the digital technology strategy that's supporting the work of the new HIS system. So you can see there a lot of policy work in progress. And a lot of items actioned in, again, I won't go through these, a lot of them we've talked about: the Center of Excellence for Aging, the family care teams, the cardiac surgery. I didn't talk on the cardiac slide. I talked mostly about cardiology, but one of the things, and I think Pat probably has a slide a little later that shows some of the improvements in the actual cardiac surgery, and we've increased our capacity to, we've increased our capacity with surgeons and our capacity to do more cardiac surgery. And so that's been an exciting development since last fall. So you can see there, we've got a few other things that are more in progress. We're looking at midwifery. We've got midwifery almost ready to go in Gander. We actually have midwifery almost ready to go in Carbonear area. We don't have this on the slide. We haven't talked as much about it, but there's some really nice work happening there around midwifery services. The two areas that are red that we haven't gotten to yet is the pharmacy support that the health accord talks about. And we really haven't spent much time thinking about the reorganization of health centers and hospitals. And the health accord talks a lot about that. We haven't gotten to that yet. And so those are red on the scorecard. And I'll pass things back to Pat.
So my part now is about the grid pillars that we've just discussed. Nearly finished, about another half a dozen slides or 10 slides or so. And again, what the learning health and social system at its basis is we're trying to match actual practice with best practice. And we want to get evidence to identify our current practice. We want to find out what is best practice, and then we want to implement change so that can occur. I'm going to give you two examples, one to demonstrate progress, but one to show how it works in practice. So on the next slide, I've just got some information about cardiac care. So the data demonstrated that access from the West Coast and Labrador was, therefore, Heart 1 was put into place, 15 flights, 110 patients came for cath, and there was 22% admitted. And which meant that the 78% went back in the plane and went home and did not stay in any hospital where they had been previously. Second one is on the right-hand side about tertiary heart failure clinic utilization. You can see in 2022, people with heart failure, 1,859 visits, 9.9% of them virtual. Patients took 6 months to be stabilized. In 2023, the number of visits went up to nearly 3,000, 26.5% virtual, and patients were stabilized in 9 weeks. And they came from all over the province. And in particular, no 17 who were living in Labrador. And then the data on the cardiac surgeries is that with the increase in resources that have gone into the cardiac surgery teams, we were doing 9 per week. We're currently doing 14 per week. We actually need to do up to 20 per week. So that's the challenge for the next year, to increase the capacity. So that's undertaken. The next slide is about stroke care. Now, stroke care was central to the recommendations that came out of Health Accord, both in terms of a learning system, using data to change practice, the idea that we had to change our approach to thrombolytics across the province, that we had to have EVT. And here you can see, and this is a kind of, to me, it's a kind of a celebration, because it occurred as health accord was been studied, and as it was being recommended, care improved. You can see here in 2018, 10% of people with an ischemic stroke received these clot-busting drugs. The national average was 20%. And the reason that it's that low is that there's a time window. You've got to get to hospital and have a CT scan within 3.5 hours. So here we are in 2022-23, we're at the national average. So that's great. And then the second piece is that for the people who are outside the 3.5 hours, there's a new therapy called endovascular therapy, where the neuroradiologist hooks the clot out of the carotid artery and the patient gets better. It started, we've done 32 cases about the middle of January this year. And the critical piece about this is that if you got the EVT, 87% went home. And during the time of this pilot project, some did not get EVT, only 16% went home. So it is a revolutionary type of therapy for stroke. And our stroke care is dependent on having a learning health system to study the elements that are associated with the pathway to therapy. So the next slide. What's going on about the NL Health Quality Council? Because we believe transparency will help, public reporting will help on the social system and on the health system. The Health Accord recommended that it evaluate each of the actions that were recommended and supported the learning health and social system, and has added a fourth element that Sister Elizabeth involved in, that there needed to be a third party who were objectively capable of looking at data governance from a strategic perspective and the ethical use of data. And that becomes even more important now that artificial intelligence is upon us. And so the piece here is, where are we with this? So there's an all-party committee has met on several occasions now to try and make recommendations to the House to put this in legislation. So I hope that would happen this year. Next slide. The biggest problem we have, of course, is human resources. There's a big part of the recommendations that had multiple components: healthy workplaces, a plan, recruitment and retention, transition guiding principles, scope of practice increased, valuing leadership and management, and having an education system that will facilitate the advent of more providers in our health system. So, has there been any progress? Yes, there has. So the next slide. You can see here that the annual renewal of licenses for physicians that occurs in January. In 2023, there was approximately 1,430. 2024, there was an additional 86 new licenses renewed. And the funny thing was, the majority were family physicians and not for specialists. Within that group, there was a degree of attrition, but we had more licenses renewed than we had over and above where the attrition occurred. And then the other piece is around new licenses, physicians, people coming in, getting the license for the first time. In 2022 was around just over, there's been 71 new licenses in 2023. There's more nurses hired, and we are using agency nurses for sure to be able to meet the need. There are more specialized allied health professionals like the radiation therapists, more radiation therapists, more perfusionists. And that leads to what David talked about, best diversions in the category B emergency rooms, more radiation therapy at home, repatriation of radiation therapy, more cardiac surgery and joint replacements. So we have by no stretch of the imagination are we saying we've solved the recruitment and retention, but we are moving along a good path, getting recruitment and retention, more recruitment and retention than we had. And I'd like to stress by no stretch of the imagination are we even saying here that our healthcare system is perfect. We're not saying that in the slightest. What we're saying is that we're taking actions to improve. Next slide. There are increased seats for providers for registered nurses, nurse practitioners, primary care paramedics, the transfer of emergency medical responders to primary care, and also in the medical school. I won't go into details, but there are more seats for all those types of providers that we need. And then the next slide. This is my own personal thing, because it's popular to say that we're overmanaged and that we need more help, more frontline workers and less management. I'm going to push back and say that's really not the case. Our percent corporate service expense in the province versus Canada is lower, it's 3.5%, whereas in Canada it's 4.3%. And it's gone down generally since 2016, 2017, matched by those numbers that you see on the right-hand graph there. It shows that we dropped from a peak of 1121 down to 994. I believe that to transform this health system, we need a strong management system. There's a lot going on. We have to respect and support what we're trying to do in trying to implement change. And the next slide. You have heard about the health transfers, and that we got increased health transfers, and that was predicated on having a plan. And we were able to give the Deputy Minister of Federal Government of Health not only the report, but the information plan to demonstrate that we meant business. We got one slide. So where are we in the pathways to change? Again, like David and I presented earlier, there's a lot of policy ongoing in all the arenas that we mentioned as calls to action. There are 3 areas where there's a red circle. The health record evaluation, but that's the responsibility of the NL Health Quality Council. An environment that values leadership and management. I'm putting that in something that needs to get better. And we need updated curriculum along the skill set necessary to integrate the social determinants of health within our curricula and our thinking. Team building, how you work in a team, how you work together in a team, and accept increased scope of practice. So there's a certain one, and then the other one is around measuring quality, being numerate, and understanding what quality means, etc. So then the next slide. Actions, same thing. There are quite a lot of actions undertaken in these pathways to change. We've got the health transformation teams, we've got digital health, we've got the new health information system, we've improvement in recruitment and retention. The learning health and social system has started. Next slide. So if we're looking at our bridge, this is the bridge between the 2 pillars. What are our foundations like here? And I think that they're actually stronger than for the other 2 pillars, because we have we have functioned with the interdependence we have with the federal government. Governance structures have been created. Digital health is in the NL Health Services. Learning health and social system has started. And of course, there are a bunch of things yet that are not integrated into those foundation blocks. So the next slide. Yes, integration is critical. We are involved in trying to access social data across multiple components. Longitudinal study on babies to work out what diseases they're suffering from in terms of their health outcomes, where they're living, and what services need to be applied to them has been funded. There's a wellbeing network, framework has been created that Lynn Taylor is responsible for. We're tracking social determinants of health indicators. And then, of course, we want to have program reports through NL Health Quality Council. So that has to happen, because that's the power of data to get change. The next slide. So what's the progress report today? What can I tell you today of the 59 calls for action? There'll be somebody out there who will add me and say, no, it doesn't. Their policy development is in progress on 28 of them. 24 actions have started, and actions requiring future work. Many depend on the ongoing actions. So there's no, we wouldn't think that trying to rationalize how we do acute care when we don't have the transition to community care resolved. We don't have the family care teams, we don't have virtual care, we don't have the ambulance system resolved. Changing acute care in terms of some of the components of it is not reasonable. Similarly with the legislation around aging, etc. So the final piece Is it reasonable to think that the health accord has already influenced people's lives? When we did this presentation for the task force, Sister Elizabeth was the EO. Well, you're not very, that's all data. Can you demonstrate that it's effective? I said, sister, it's too early. We wouldn't think that these things that we're trying to do could have an impact within 20 months. But then when we got down and looked at the data, we thought that, yes, I think there are places where you can say, yes, you should feel it. So let's have a go off this now. This is not, I'm not trying to wave a flag or anything like that. I'm just, I'm just saying is that you look at it, it's reasonable to think there already are benefits. So the childhood benefit program, I have more money in my pocket at my children's expenses. The employment stabilization program, my partner can maintain a stable income while I'm re-entering the workforce. The increase in the number of seats and the increased scope of practice, etc. My cousin has a better chance of receiving training at home, won't have to move their family out of province. The increase in the number of visits that are occurring in the kayak clinic. My niece in alternate care is receiving wraparound services. There's no, where's it content? Oh, yes, sorry, I missed it. Thanks, sister. There's over 50,000 people connected with family care team. So my family is attached to a family care team. You can feel that. Next. That's not to say there's another 50,000 need to be. I totally acknowledge that. But you should feel the 50,000 people. My child can receive appropriate care at an urgent care clinic for their sprained ankle. Don't need to go to emergency room. That's occurring in some regions. The next one, my family receives care at the closest emergency room when they really need it, which is this is the improvement in that there's no longer diversions from emergency rooms in the category B places. My family receives care without having to travel as often, driven by the increased use of virtual care. My grandmother returned home after she recovered from her stroke, driven by the improved quality of care for stroke. My mother no longer gets angina all the time, driven by the increased numbers of cardiac surgeries that were undertaken. My grandfather was able to walk without pain after his knee replacement, driven by a 50% increase in hip and knee replacements. So and my dad no longer needs to leave the province to receive his radiation therapy, driven by the repatriation of radiation therapy province. So I have to bow to Sister Elizabeth in terms for this one, and that she felt that it should be feasible to put human face on the things that we're trying to do. And that's our feeling that there is a human face in some of it already. And then the last slide is, what does our bridge look like? So we see over the next number of years these building blocks that are necessary to change the social determinants of health, but it's going to be much slower than changing the healthcare system. Guarantee it's going to be much slower. And then the healthcare system, that their building blocks around those multiple pieces that Dave talked about, that will be a secure, integrated pillar. And then the connections between the social determinants of health and the healthcare system and the bridge to better health outcomes, driven by these pathways to change, will occur because we've already started. We've already got policy. We're implementing quite a lot of this already. So I'll stop there now and we'll take questions.
Okay, thanks very much to all of our speakers. We have audience both online and in the room, and we're going to offer you an opportunity to ask your questions. So if you're in the room, there's a microphone here that you can use so everybody will be able to hear you online as well. And for the people online, as has been put in the chat there, type in your questions, we'll verbalize them for you. So I'm going to alternate between both here in the room and people on the left. And I'll start with here in the room. Does anybody have a question for somebody on the panel? If not, I know we have some from online, so Melissa, maybe we could have one of those.
Yeah, for sure. That's no problem. Let me see. Here we go.
How many do we have on, by the way?
About 70, 75. Let's see, a question here from Angie. Historically, community partners like Empower and the Autism Society of Newfoundland and Labrador have been the main sources of advocacy for clients who are disabled and or neurodivergent. What actions are being taken to ensure that the silo that has been healthcare to date will change to also include the patient voice and their advocates in a meaningful way, and accountability if and when that action doesn't occur?
We talk about the healthcare system out there.
Yeah, thanks, Angie. It's David. I'll just make a few comments from the health authority's perspective. So again, we have already from the previous systems some mechanisms for patient and family input. At community levels around the province, we have community advisory committees, and so we get input from at that municipal level for a certain level of input. We also have, through a lot of our quality mechanisms and some program areas where we have patient and family centered councils, where we get cancer care is an example that I'm somewhat familiar with, where there's a patient and family council that provides ongoing advice to the cancer program, and that's, I know, very valued, and members of that council are integrated in a lot of the decision making and new initiatives that come up in cancer. And so we have every intention of continuing with those mechanisms that existed in the 5 previous organizations and building on that in a strategy for patient and family-centered care. The other thing at the board level that we've been doing, and again, this is early days, so I don't want to reflect that this is in any way done, but it's 11 months in. But at the board level as well, we have developing a community engagement committee where we anticipate a board committee with members of the board and some members of the executive who will meet on an ongoing basis with a variety of community groups, some of the kinds of groups that you've talked about. And just as an example, in our last board meeting, we had a focus around mental health. And so Gathering Place as an example, and the Schizophrenia Society were 2 of the groups that actually came and spent an afternoon with the board and actually got to speak into that governance level. So lots of work to be done, and I wouldn't in any way say that we've spent enough time thinking and adding to structures to make things particularly better than they were before. But we do want to build off that, and so I know our VP of Quality is very much interested in that family and patient centered council kind of concept, and we think that'll be one of the areas where that kind of discussion will continue.
And I might add to that in terms of policy development, in terms of the disabilities group who feel that they're excluded, and their health outcomes are far worse than the health outcomes of the general population. So there's obviously a need to be able to have a whole of government approach to disability. There are several departments of government that are actually active in that area, but we are trying to develop policy that allows that more integrated approach, particularly in the 4 big areas: awareness and education concerning discrimination, social determinants of health actions. That's what David talked about, is access to health, to the health system, and then an approach that would be related to disabilities within well-being communities.
Melissa, can I ask Pat as well to speak to another important structure, which is the regional well-being networks? Because I think that one gets down to the geographic areas where we can build inclusion and connect all those kinds of community advocacy groups. Pat, can you speak to those?
Right, so the Health Accord recommended regional health and social networks, and we reframed them to fit without the use of the term well-being. So there's envisaged that there would be a network in each of the 5 regions called a regional well-being network. it's envisaged that they would, that table, you'd have the principals, the leaders of the people who are responsible for health and justice and education, and the social system, and the Indigenous nations and the community sector in their region would come together and discuss the problems in their region, informed by the data for their region, and come up with solutions to the social determinants of health problems that they see, and then connect to central government to be able to influence policy so that so their voice is heard in changing policy. So those well-being networks are certainly I gotta be careful here. I'm optimistic that there'll be 2 pilot networks start in the coming year.
Okay, so anybody in the room would like to ask a question? If you would like to go to the microphone, please.
Hi, good evening. Thank you for this wonderful report. I'm Eva Pagam, Dean of the Faculty of Nursing. And I don't think there'll be any argument in the room that in all the strategies that nurses play in a period role. And in what I do see in there is a role for nurse educators, particularly, we have the Center for Nursing Studies, the Western Regional School of Nursing, and of course, Memorial. And we've all been involved in increasing the mandate of the seats and the satellite seats in our rural regions and the Dolan Nurse Practitioner Program. But I just want to get your thoughts, and I'm sure, Mr. Don, you can know where I'm going with that. With this, is about in 2005 there was a call for action for the consolidation of the nursing schools within the province to be able to provide a quality education that is more efficient and to increase our capacity for our nursing graduates in order to help this vision come to fruition. But of course, we're struggling with our infrastructure to be able to do that, and it exists now as 3 different entities under 2 different unions, which is impeding our ability to function in the most efficient way. We want increase our graduates to work in these family clinics, to engage with these seniors in their dementia strategies, to be into the schools, and play a very, very strong role in helping you bring this to life. So I'm just wondering, if there's any feel about that, because it's been 20 years and we are feeling the strain, and we will not be able to produce the graduates that we might.
That's what I would answer.
I can make a comment or two, and then others can add. I mean, you're speaking my language, because as one of my failures over 10 years is I honestly believe in the integration that's been talked about for the 20 years, and I haven't been able to push it far enough in the 10 years I've been here, even though from an Eastern health perspective, we've always supported it. We do see the nursing education programs as a real fundamental piece of the transformation, and actually, and you're doing that now. And I think in the HR situation that we've been in, and what the schools have done around, being in Jamaica and training LPNs, and back in Jamaica again now, looking at the similar programs, doing a lot of work on the international level, training up internationally trained nurses that live in the province but need some additional support. And a lot of those creativity has come actually from the nursing schools themselves. And so you folks as leaders have really helped us quite a bit in sustaining ourselves. And I particularly think about that in the HR situation that we've been in and are still somewhat in now. So, I mean, 2 things I would say is thank you for the creativity and the work that, what the nursing schools and the programs bring, because frankly, there's a lot of what we're doing we couldn't do without that creativity. And the second thing is I'm 100% in support of what you're talking about. And I think, I think the government as well at this point is also in support, but it's as you know, there's been one hurdle after another. And so we're facing the latest one now, and eventually I think we'll get out the other end of it. But I think there's lots of support for what you're talking about.
So I would make the same comment, and I can only give you my personal opinion, is that it appears to have stalled, and it's up to the players to make it unstall. The government can't make it unstall. The NL Health Services can't make it unstall. is the players will come forward with a plan about how they would agree to consolidate and what resources are necessary to enhance that consolidation. And on a personal level, it seems eminently obvious that is a good thing.
There is a plan ongoing, there's a task force for consolidation of nursing province, but there are multiple barriers. But the 3 schools of nursing, actually 6 sites are now, are committed to helping bring this action to fruition. But we need the resources, mainly I need space.
For those online who may not have heard that, the answer was that they need some space and resources, and they are willing to come together and have a plan and a task force, and are working towards a solution of integration of nursing. Melissa, anybody else online?
Yeah. David asks, please explain the difference between a provincial program and a strategic health network. Aren't they both a way to integrate a particular service provincially?
Yeah, they absolutely are. I mean, in our structure, there's several pieces to the structure, and designing an organizational structure is a little bit about science and a lot about art. I think, as we've looked about and done jurisdictional scans all across the country and elsewhere, there's some common elements across these kinds of provincial systems, and then differences as well. So when we did our jurisdictional scanning, and where we ended up at the end of the day is to think that the foundational piece of the day-to-day operations of the system really needs to happen as close to patients, as close to providers and communities as possible. And I think the health accord actually speaks to that around keeping decision-making closer to home, as opposed to centralizing decision-making. And I can speak from my experience, having lived this in Alberta, where the first iteration of a provincial program was all about centralizing. And so you can imagine if we centralized all decision-making in St. John's, what a mess that would be. And so we intentionally designed this in a zone-based structure where the leadership and the decision-making remained as close to the local geography as we could. So the day-to-day operations is, for the most part, designed to happen within the geography. But of course, we can't really get the benefit of what a provincial system is if we didn't have ways of tying that together to drive quality, to drive standards, to drive access, to ensure patients flow through the province so we can maximize the infrastructure that we have to the benefit of everybody in the province. And so we needed those integrating mechanisms that's talked about in the question. And so we have several of them. We have provincial departments, and all of the provincial health systems across the country. If you go to Alberta or Nova Scotia or New Brunswick, which has 2 systems, French and English, but is essentially provincial health authorities, they all have a small number of provincial departments. And provincial departments, Cancer Care and Eastern Health is a good example of a provincial department where you have a provincial director of cancer care, you have a leadership team which is centralized, and then everybody, wherever you work in the province, you report up through that structure. There's one strategic plan for cancer care, there's one budgeting process for cancer care, and it all comes up through that structure. And we had cancer care, we had health and corrections was designed that way, so we decided to leave those in place. Cardiovascular care was a big priority coming out of the health accord and for government. And so we decided we would do that as a provincial program. Medical imaging and lab lends itself to that. And there was actually, prior to the decision on a provincial health system, there was actually a decision by government to manage those as provincial services. So we looked at a small number, and there are other programs that could be in and some that could be out. That's the art of this. There's no magic to it, but we left some in because they were there already, and we added a couple of others because they were big priorities like cardiovascular care. But if we ran everything by provincial programs, the zones wouldn't make any difference, and the decision making at the local level would be gone. And so we only wanted to have a small number of provincial programs. But again, I think the premise of the question is we need, in the absence of everything being a provincial program, you need ways of tying things together. And so there's 2 ways we're doing that. One is with clinical networks. We'll think there'll be about 15 of those. We talked about surgery and emergency services and primary care and seniors You know, we think there are other things, mental health and addictions probably needs to be there. Pain is another area that we've talked about. You know, there's any number, but we think about 15 we can handle. And the difference between, you know, the provincial programs, you have a leadership structure and decision-making that's centralized. In a clinical network, so a clinical network for surgery doesn't mean the day-to-day operations of surgery is run by the network. You know, if you're in the new hospital in Corner Brook after June, the day-to-day operations of the OR and the surgical units there will still happen within the geography close to where patients and providers are. But to drive innovation and change, those people will be around the table in a network looking at, you know, big initiatives, transformation initiatives, research opportunities and so on across the province. So that'll drive a level of change. Now, we probably could do 40 networks, but their resource, they have, you know, directors, they have medical directors, they have change management people, they have data specialists. So we can't really resource 40, plus we probably couldn't deal with the outcome of 40. So if you're not a provincial program and you're not a network, there's still an opportunity for services to be connected provincially in another integrating mechanism, which will be less intense than either of those and a little less resourced, but still allow people to come together and share ideas and look at best practices and so on. So there'll be those four mechanisms that really are the foundational pieces of our structure. That's probably way more information than you asked for in the question, but there you go.
So I'd just like to add to it way more information. So, I mean, in the Canadian health system where the taxpayer funds funds healthcare, we all observe across the country kind of a disconnect between the political system and the health and community services and the delivery system. So we've tried to come up with some innovative approaches to have alignment across policy implementation and political decision making through the use of health transformation teams at which sit the principal in the NL Health Services, the principal in Health and Community Services, a member of the health transformation team, and other people that are relevant to the delivery of that call to action. So seniors care would be as a transformation table. And we've also thought about how do you do it? How do you do the same thing for the social determinants of health, which are more complicated, require more integration. They involve multiple departments and they involve people in the community who feel that they're disenfranchised by government. So we're trying to put together a similar thought process whereby you bring together we're calling them working groups, but they're in effect groups of people that would have the principles within government for a particular problem, the principles that you would identify out in the community for a particular problem, a transformation person that would kind of be the secretariat, and then try and get alignment from a policy and an implementation practice perspective that integrates government and delivery, just like we're trying to do for the health system.
Okay, thanks very much. We had some questions submitted by people when they registered. Okay, I'll get to you one sec. This is a relatively short one here. It just says that the questioner recognizes that there's a multicultural growth in the province and brings out that there might be a number of challenges raised by that, including racism, misunderstandings, communication difficulties, and so on. And wondering if there would be plans in place to support both the patients and providers in dealing with these challenges.
Yeah, so the short answer is yes. Under the Darla King, who's our VP of Transformation for Wellness, there's a focus on inclusion, diversity, and inclusion, and the areas that you've talked about in the question. And again, early days, so we're consolidating some of the mechanisms that existed previously, and there was in the old Eastern Health days a diversity council, DEAR Council, diversity and inclusion and equity and reconciliation, I think is the R, and we're building off that, and that has a diverse membership from a variety of the groups that you've talked about. So yes, there is a focus, there is a vice president that has that accountability, and there's a director in our system that has those accountability, and we're pulling together. I mean, that's one of the mechanisms. There are other mechanisms from Western Health had quite a major focus in Indigenous, and of course in Labrador, the Indigenous piece was a big part. All of those things are coming together under that transformation area, and it is already starting to be a focus. The board is also interested, I would say, from a governance perspective in diversity and inclusion issues, and part of the role of the Community Engagement Committee that I talked about earlier will be to have a focus from that governance level on those kinds of issues.
I'd just like to add, Brendan, to that question about immigrants. So obviously we've had thousands of immigrants in the last number of years, and it's a kind of a quickly arising issue about how do you retain immigrants? And it's just not a kind of a responsibility of the Department of Immigration. I don't know what it's called, but for them, there are massive issues around the social determinants of health to meet their needs, because they want to get education. I wouldn't say amazingly, now they need transport. They need and they're always, and the immigrants are paid less, and they make less just by the nature of the fact that they've come to a new society, and they can, so their income is probably about 20% less than the regular population. So the situation here is a multifaceted problem, and there needs to be a multifaceted approach to it. So, and we are having discussions within government, and would be taking those discussions outside of government to try and see how we can do a better job.
Thanks. So we had a question in the room. If you would like to go to a microphone so everybody can hear you online as well. Thanks.
Good evening, Cindy Holden. I'm a registered dental hygienist, but sort of an advocate of public oral health. I had a question. One of my questions might be on your Brandon, but I'm curious. The program you mentioned earlier, the seniors, the federal collaboration for seniors dental, got my attention. So anybody elaborate on that just yet?
The question is about the interrelationship between the federal government's dental plan and what's going to happen in the province.
That could be where.
It's starting with
dental for seniors, and it was a federal government.
Right.
It was that, was it?
Yeah, it was, yeah.
Okay.
And it started with the oldest,
Yes,
and now it's gone
exactly.
down to the next group, and now it's gone down to the next group.
Yeah.
So there is undoubtedly connections between health and community services and the federal government to roll out that program for seniors. Yes.
We haven't developed policy specific around oral health yet, although I'm thrilled to see how much investment's gone into the health schools and the education piece, because that's the most equitable,
Right.
For health literacy for sure.
I can't answer your question.
Okay, we'll try and do that in the future. Melissa, anybody else online there? Yeah.
Yeah. Glenn asks, what are specific timelines for investments for the social determinants of health from the Health Accord NL, the social and economic well-being plan, poverty reduction plan in areas like housing, income, food security, employment, education, etc.?
Well, I mean, I can only speak to what's in the public arena, and I speak to the poverty reduction plan is close on 100 million investment in 2 years. That's pretty substantial. And then I can't tell you the amount of money in terms of housing that would entail. But I do think that the information that I presented on the rollout of investment in or actions in the social determinants of health implies to me anyway that the government has that their policy, their decision making demonstrates a strong connection to improving the social determinants of health. I also will say that they'll never make everybody happy. And I will also say that problems arise that need solutions like the homelessness problem needs solutions that span more than just having housing solutions. They include wraparound supports, etc. So these problems and the solutions that are associated with them are going to be there all the time. The capacity for government to increase the funding to be able to act on these particular areas, I would think is partly political, because we give more credence to having a family doctor than we do to getting rid of poverty. The downstream effect of that, of course, is poverty is more important in terms of the adverse health outcomes. So the political support is in favor of spending in the healthcare system. It's self-evident. You've got a $3 billion budget, 40% of the spending that's happening, whereas the downstream health benefits of increasing spending in the social terms of health are highly likely to be substantial. And the biggest investment is in prevention of childhood poverty, that it'll have the biggest bang for the buck than anything else. So you've got this tension that Canada, and that's not us, just Canada, is that Canada, we have developed a health system across all the provinces that is valued more by the population and spending in the social terms of health. So the statement in our vision statement was, are we capable of increasing the awareness of the importance of the social terms of health and then intervene? So that's our challenge, I think. And then on top of that, you've got the fact that it's hard to do. Do you know what I mean? It's hard. Interventions that improve inclusion are hard to do. So, but we've started is probably what I'm getting at. And I'd love if we were like, I like our focus on being a well-being province, and I like the fact that we've acted on several different things in that particular arena. My last comment, I suppose, is that this is not a government of Newfoundland issue. This is an issue for all of society. That well-being, the pieces that we think of well-being from those elements that comprise a well-being community, there are capacities within communities to improve the well-being of their residents, whether it's through transportation or social or civic programs or housing or inclusion or whatever, that can have a big effect on well-being. And so it's not necessarily the government's responsibility to put money into a solution. It's all of our responsibility to try and act in improving well-being.
Thanks. We can take a little more time for a few more questions if there's interest in that. I see somebody standing up here in the room.
Andy Fisher. I want to start by thanking particularly the three of you for leading the initiative. I think everybody who asked a question was focused on, the thing that they're thinking ahead, but this is quite a ways to have moved in the time that is spent. So I think we should all celebrate that. And I think you have truly raised the social concerns of health, onto the radar, at least of many. So I think that's amazing. A question for you, Dave. I'm sorry to hear that you may be moving on to other things. So the Dave Diamond fan club, what to do next. But the question for you, we talked a lot about the challenges, recruitment of attention within the organization. And I feel like all of this is happening. All of this can be a change, it can be a challenge to individual working system, but it could also be something to celebrate. I wonder if you're seeing any movement in the positive direction of people feeling like the system is getting better. Is that sure?
Yeah, it's a great question. I mean, it's pretty early days. One of the things I would say from where I sit is I actually think the merger that we've undertaken is probably the biggest corporate merger in the province's history, to bring 5 organizations together as we have and meld it into one. From my perspective, it's gone way smoother than I might have anticipated, having lived the experience in Alberta where it didn't go as smooth and is still not as smooth as it turns out. So I think that says to me that there are a lot of people who share the kinds of values and the kind of vision that, the health accord sets out. And, I've said in other, I've had the opportunity in a couple of provinces now to talk to audiences about provincial health systems and mergers into provincial health systems. And I've used the health accord as one of the things that I think we did in this province very well, because if I look at the experience in other provinces, including my experience in Alberta, where there was not a common vision. And so government, in the case of Alberta, announced one day they're going to a provincial system with no conversation around what that meant, no effort to get any kind of a provincial or a provider consensus that made any sense. And then the organization was left, for the next 5 years to convince everybody that it was a good thing to do. I feel like we had that conversation as the health accord, the rough consensus, a general consensus, I think, in the province that this makes sense came out of that. And I think that spills over into the health system as well. So, my sense is, and I'm sure this is not 100%, but a lot of people in the health system generally are rowing in the same direction at this point. And we're seeing that, so I think we're seeing that some sense of a common vision of where this province could go, including our part in the health system. When I look at some of the big projects like the IT project as an example, and so we're starting to see, we saw people well in advance of us actually even getting the approval, reaching out, wanting to come into the health system now, some from other industries, some who left health and came and are coming back. And so in pockets, we see people coming back into the health system who've left, people who, maybe opted out of permanent employment, coming back into some of that. So little pockets of those kinds of things say to me that I think, there are signs that we're heading in a good direction. And again, I think the health accord set us up very nicely as a health system to do that. Even in our own executive team, as we put that together, we had several people come back into the health system, coming back from other provinces who had left and gone, and now they've come back to join this effort. People from other industries who've come into the health system. So we're seeing bits and pieces of that. I have no illusions to read too much into that, but just off the top of my head in terms of your question.
I'd like to give a response, Andy, insofar as the analogy with the bridge and the pillars. That's the truth. We're only just started. We're getting very light coating of cement in which we're putting a few of those building blocks on, and then we've got to add in all those other building blocks. But I do support Dave in the feeling that there's a positive feeling amongst the people who are responsible for change, but they're swamped. There's so much happening at the same time. They're under pressure, whether they're in NL Health Services or in Health and Community Services or in the social arenas. They're swamped, and the pieces that have been defective as a consequence of a stretched system before COVID came, and then the loss of 10% of the providers during COVID who never came back. That pressure is still there, and by no stretch of the imagination are we trying to say that we've solved the problem. There are people still don't have access to a family doctor. There are people who have long delays in emergency rooms, etc. So it's still a system that's in some degree of pain, but I do believe that there is a far bigger optimism amongst the people trying to run the system and to deliver the care.
Thanks. Let's see if there's something else online.
Sure. Could you discuss more about the government of Newfoundland and Labrador and NLHS vision for immediate, short-term, and long-term vision for virtual care in the provincial health system?
I, yeah, I can make a few comments. I mean, I do think, virtual care is not a panacea, and it's not a replacement for everything that we do in the health system. But I think it's a huge part of what will sustain us going forward. And I think that the technology is improving every day. A lot of the new technology, even things that we're doing in terms of our own innovation approach here in the province, things, what we're able to do now in supporting patients in places like Black Tickle, for example, or Nain or Hopedale, is actually quite amazing in terms of specialty services, in terms of point of care testing, in terms of devices that, can measure your heartbeat or do an EKG. And, so I think what we're doing currently with the ability to cover Category B emergency departments, to provide primary care. We've been doing a lot of that locally with our own providers in terms of levels of virtual care, and now what we're able to do in a remote way. And the technology is only going to get more sophisticated and better, and we're going to be able to do more and more. So I think from where I sit in NLHS, our ability to sustain this rural and remote geography that we have and provide a level of equity in services wherever you live in the province, virtual care is going to be a huge piece of that. Now, that doesn't take away from the fact that, sometimes we need hands-on. Sometimes you need to come to a center to get care because that is the best way of doing it. So it's not to say that everything that we're used to and everything we know works really well goes away. But I think virtual care will close a lot of gaps, and I think it'll do a lot for equity, because if you have to fly from the coast of Labrador into St. John's several times a year to get your care, we're being told by many patients that they're not able to do that for all kinds of reasons. They're not able to do that, and so we can actually bring the care to them. Sometimes it'll be a traveling clinic with a specialist going from here to a place like Goose Bay, which makes it closer. A lot of that care can also be done in a virtual way. And so we're very interested to see where that takes us in the next little while.
Virtual care is here to stay. Buy into it, make it work. It fills gaps.
Yeah, thanks. Have we anybody else in the room like that? Yeah.
Hi, everyone. My name is Daniel Hogan. Kudos to everyone involved in the health board. It's amazing to see all the progress we've made today so far. We just wondering if we can speak to one component that you highlighted earlier in the presentation, the climate change aspect. So, probably well known by everyone, that climate change exacerbates a lot of social determinants of health. There's going to be things like that. I'm setting one differently. So, I wonder if you can speak a little bit to if you do have any plans in place for, assuring like a climate resilient health system here within the province, if there's any like adaptation or mitigation efforts underway, coordination with say like the federal government or with the federal government.
I'll speak to that in so far as what you're saying is totally correct. It's the biggest problem in front of us, particularly in the longer term, and being able to come up with a provincial approach to how the climate change is going to affect health, and how it affects the health system, and how it affects social issues. It is really important. So you might say to me, well, why the hell didn't you get involved in it last year instead of saying I'm going to do it this year? Because we were swamped. We are going to do it. We are going to try and have an approach to the climate change, but there's a limit to what a certain group of people can do.
The other thing I would add to that is actually, I mean, in addition to us understanding climate change and being able to deal with the health outcomes, the health system is actually a real contributor to the problem, I would say, and we don't talk about it very much, but the health system is one of the worst. You go into an emergency department and you see all of the single-use contraptions that we have, and all coated in plastic and styrofoam, and you tear it all open and you throw it away and the piles up, and then we throw it in the landfill. And over time, we've gotten worse with that because with infection control and so on, we really, the pendulum has gone. We don't reuse anything, even things that we probably could reuse. Plus, we put a lot of anesthesia gas, for example, gets pumped out of our ORs out into the atmosphere, which is some of the really bad stuff that goes out into the air. So there's a lot for us to be doing as a health system, even in our own footprint. We do actually have some things as part of what our innovation strategy has helped us with, some new technologies around capturing anesthesia gas actually to be reprocessed and reused in the ORs. And so we have some of that activity that's happening. But we have a lot of work in energy efficiency and reducing our footprint in terms of better use of energy. So those are some of the things that have been happening. There's a lot more of that can happen. So we have a lot we can do. And fortunately, our board has taken this on and are developing our own internal sustainability strategies as well. So lots more to come on that, but tons of opportunity within the health system, even before we think about, you know, how we interact with what's happening in the community. We have a lot of work we can do ourselves.
It's done that too. If anyone's interested, Quality of Care and Health put out practice points as a kind of a knowledge mobilization tool, and we will be including focus on the climate impact and things that are being done and what has changed. Out in the next few months, there'll be several papers that you might be interested in on that. Melissa.
Yeah, I think I have one question online that might be a good one to end with this evening. Someone has asked, what is the structure that will be used to evaluate the results and effectiveness of the Health Accord going forward?
So I can answer that. It is envisaged that the NL Health Quality Council has that responsibility, that it would create the projects that are necessary to evaluate the actions, and on the social side and on the health side. And all these actions are now being propagated through various structures on both the social side and the health side. And the data is actually available. So we'll be depending upon the learning health system within the acute sector and the long-term care sector and the community sector to provide the data. And as that learning health system gets more mature, the projects that are going to be able to evaluate actual practice are going to get more sophisticated. But even at the present moment, it's feasible to use the data that we've got to influence practice and do things better. So we visualize that the NL Health Quality Council would report to the public on the CI health indicators, which would be telling us how well our system is performing, and which would be a major way of kind of educating the system about how we're doing. And we would expect the council to be reporting on the various calls to action that came out in the health accord. And as you can see, they influence everything, right? You just, from our presentation, it's got, you know, it's just enormous. So it'll end up that you have to pick and choose what they report on. And as a consequence, we feel that the board for that council should be comprised of patients and the public far more than subject matter experts.
Okay, well, that brings us pretty much to the end of our time. So I'd like to thank you all here in the room and online for participating in the discussion and contributing your thoughts. We would also like to express our special thanks to our three speakers here, Sister Elizabeth, Dr. Parfrey, Mr. Diamond. You've brought us up to date in our implementation. I think there was mention that we may come back to this again. Hopefully we'll have a further update in the future. For those who couldn't participate today, they will be able to see or hear what went on, because the recording of this session will be up on our YouTube website fairly shortly, within the next few days, I think. So thank you again, and safe travel.